Hi, folks. Welcome to the Award Network webinar. I'm just going to give it a moment as people join our meeting today. Okay, looking like the attendee list is growing and people are still popping in, but I don't want to take too much time away from our wonderful webinar today. First off, I'm going to just introduce myself and do a little housekeeping and then turn it over to our host of the webinar for today. Thank you so much for joining us today. Morning for those on the West Coast, lunchtime for those on the East Coast, and somewhere mid-morning for the rest of you all. Great to see such great attendance for today's webinar. Again, this is the Award Network monthly webinar. Again, award stands for the Advancing Workforce Analysis and Research for Dementia. The Award Network is a National Institute on Aging funded activity to bring together researchers, policymakers, other stakeholders who are interested in really moving forward the research in the field of dementia, really trying to support patients living with dementia. And we're fortunate to have these monthly webinars being organized by a wonderful webinar committee, one of who it will be who really organized the event today. But before I turn it over to him, I did want to just remind folks that again, we're trying to do these monthly. We try to post the webinars soon after the webinars are over on the Award Network's website, which is at awardnetwork.ucsf.edu. You can find a lot of other information there too, including who's on the leadership team there. My name, I'm Bianca Frogner. I'm one of the members of the leadership team. I'm a professor over at University of Washington and the director of the Center for Health Workforce Studies. So I'm really excited to be part of this collaboration with UCSF in carrying out the activities of the Award Network. Also, feel free to follow us on social media at award_UCSF. And this is where you'll learn about activities upcoming through the Award Network, including hopefully more monthly webinars. We have a really exciting lineup of speakers that we're starting to pull together. But something else to really keep your eye on is that many of you are probably attendees of the American Geriatric Society. Their annual scientific meeting is coming up in Long Beach, May 4th through 6th. And the Award Network is actually planning an event for May 3rd. So please hold your May 3rd dates. The event will be taking place from 11:30 to 5:30 p.m. Invitations are coming, so just wanted to give people a heads up to look for that. There will be sessions, including some networking, speed sharing, brainstorming on databases, and there'll be a panel on equitable care of the workforce and their clients, and lunch will be provided, so you won't go hungry. So I'm really excited to have this webinar, which was organized by one of our webinar committee members, Hui-Wen Xu. He's an assistant professor at University of Texas Medical Branch. I'm going to turn it over to him to introduce our speakers for today. Yeah, I'll let him go ahead and take it away.
Thank you, Bianca, for the introduction. Hi, I'm Hui-Wen. I will be today's host, and it's my great pleasure to introduce our two distinguished speakers. The first one is Dr. John Boblis. Dr. Boblis is a professor of economics in the Farmer School of Business and a research fellow with the Scripps Gerontology Center, both at Miami University, Ohio. He also has affiliations with the School of Aging at the University of South Florida, the Bratt Groups, and the Economics INC. Dr. Boblis provides testifying and non-testifying expert consulting service, including economic and econometrics analysis in complex business litigation and regulatory matters. Our second speaker is Mr. Sam Brooks. Sam is the Consumer Voice Director of Public Policy. He is an attorney formerly with the Aging and Disability Union at Community Legal Service in Philadelphia. During that time, He became an expert on nursing homes in Pennsylvania and nursing home regulations. Sam has a passion for justice and years of advocating on behalf of nursing home residents. Just a little housekeeping. So first, Dr. Boblis will present for about 35 to 40 minutes. Then we will switch to Mr. Brooks for another 10 minutes comments with his slides. And we will keep all the questions till the end. So feel free to drop the question in the Q&A and I will monitor them. So John, it's your turn.
Okay, well, thank you for being here, whether it's afternoon or morning, depending on where you are. What I plan on doing today is talking about sort of nursing home staffing regulations generally. Obviously, the basic motivating factor behind this, and everybody's aware, is last year, our President Biden in his State of the Union address, made a big deal about protecting seniors that are living in nursing homes. And there's a rightful reason for that. I mean, the COVID pandemic put a spotlight on nursing homes. In particular, we know that there's over 200,000 individuals, whether they be residents or staff members, who passed away. We do know that, nursing homes are a big federal outlay and even state outlay in terms of tax dollars. And there have been sort of quality issues that people have reported in nursing homes for a long time. And so in order to improve that quality, which is the main focus, the Biden administration has put together an effort to try to reform the nursing home industry in some way. And the one that I'm going to focus on today is the federal staffing requirements. What I want to do in understanding this and just really focusing on that aspect of this is to understand what is the main purpose. The main purpose of any regulation is to assure that we are providing the best quality to residents, right? So we know that there's generally an association between staffing and quality. But the thing here that we want to make sure that is emphasized throughout this sort of talk is that we're focusing on staffing not because we care about staffing, it's because we care about the end result or end outcome, which is assuring quality. And we think that this is one of the policy mechanisms that can be there to sort of improve quality in some way. So to understand, sort of what the Biden administration wants to do and what are the problems that states and CMS have to think about, it's important to understand what the current staffing regulations are. Right now at the federal level, there is a regulation that basically is very simple. It just says a nursing home must be sufficiently staffed. If we want to think about the actual words, it's that you need to be sufficiently staffed to meet the needs of the residents so they maintain their highest psychosocial, mental health and physical health and some other things. But when we get into the heart of what that regulation says, what it basically says is that a nursing home needs to assess the needs of its residents and from there determine what's sufficient. If we look at this in terms of hard numbers, so what I'm talking about is quantitative benchmarks. What are the specific numbers a nursing home needs? The federal regulations are a little bit silent on this. The only requirement that they have is that you need to have a licensed nurse that is an LPN or an RN on duty at all times, with at least 8 hours of that being an RN. There isn't any specific minimum number that's associated with the number of CNAs. There's nothing in terms of total staffing and whether that staffing includes administrative or whether that's only those people focused on direct care. So that's what the current status is for the federal regulation. Now, what happens is that because we have 50 different states, each state can also implement their own state regulation related to nursing homes. And so what happens here is some states have implemented minimum staffing requirements. The one that's probably getting the most attention right now is New York, because they had tried to implement one during the middle of the pandemic. It was delayed. And now that you have to have 3.5 hours per resident day of direct care. So you can see that New York has sort of now implemented this new standard. Before, I believe it didn't have an actual number requirement. If we look at, for example, a state like Texas, Texas's current requirement is that you have to have a 0.4 hours per resident day of licensed staff but there isn't any quantitative minimum that's associated with other types of staff, such as CNAs. So what happens here is that, what is sort of the standard of care and what's going on is different in each state and needs to be looked at within those contexts. So the question is what do we do if we think we need to sort of implement stricter regulations? And right after the Biden administration's, or Biden's State of the Union address in 2020, we have this NASEM report that came out that sort of, this huge report about, how should we potentially reform nursing homes? And one of the things that came out of it was discussing staffing regulations. In particular, they had two key recommendations. Number one, that there should be a minimum nursing staff level for direct care so that we actually quantify what is the minimum staffing level. The second thing is they suggested that maybe what we need to do here is that we also need to have a percentage of expenditures from the government sources spent on direct care as well. And while they might have looked at all direct care, some people might look at that as just spending on nursing staff as well. So the idea here is that there would be this combination of potentially minimum number of level in terms of hours, but also how much are you spending? While I will say this, that the recommendation focuses on government revenues, there are other regulations out there that sort of suggest that you have to treat people who are on different payer sources the same way, and likely any requirement for the government revenue is also going to be applied to private revenue. It's hard to implement that otherwise. But I want to focus on sort of the key overlooked facts about this recommendation. One is that the NASEM recommendation is that you need to implement both. That the idea here is that if you're going to have a minimum expenditure, you need to have a minimum staffing level. However, when we start talking to people who are in the policy space and people who are, advocates, some people are only looking at the expenditure requirement, saying maybe that solves the issue. So the purpose of my talk is to sort of talk about these things and what, what's going on with this. So if we look at this, I want to talk about some of the things that you should consider when you're looking at a minimum staffing level. From a policy perspective, what's great about a minimum staffing level is it's very concrete, right? If you hit a specific number, we know that you are then, meeting that sort of criteria. It sort of guarantees a level of staffing. But once we get past that, it gets a little bit harder to understand, what are some of the things that we need to consider? One, we know that nursing home residents are different. A person who's on Medicare getting post-acute care might have a different level of need than somebody on Medicaid who's a long-stay resident. And so therefore, the question is if I'm a facility that has a lot of Medicare individuals versus, say, a lot of Medicaid individuals, should I have the same staffing level as being my minimum? So the first question I think that needs to be asked is, do we need a resident-specific type approach to figure out what that minimum is? Or do we try to use a one-size-fits-all? The second thing I think is important is that what happens when you create a benchmark or a minimum is that you basically set a benchmark. And so what happens is that becomes what people refer to. I worked with Andrew Gaddis. He was an undergrad here at Miami when we were doing this, but we looked at New Mexico and Vermont. And what happened in the early 2000s is both of those states had no minimum staffing requirement, but they implemented one. And what we wanted to see is what happened to staffing once they implemented it. And what we found is those facilities that were below the minimum increased it. That's understandable. But what we also found was those facilities that were significantly above the standard reduced their staffing down to the minimum. So the question here is if you create a minimum, are you essentially creating what the standard is? And so therefore everybody staffs to the minimum. Particularly the third issue that's happening today is, do we have the workforce that's available to fill these positions? If you listen and talk to people who are, in the industry, they're finding it a hard time to find workers. They're having a hard time finding nurses because they know that the staffing agencies are paying more. The nurses are getting more money in hospitals. We also know that CNAs are competing against other places that are offering significantly higher wages, such as Target and McDonald's. And so what's happening here is do we have the amount of workers that if we wanted to implement, say, a higher minimum, do we have the people there that could fill those roles? Another issue that I think needs to be addressed is there a need for government funding? Right now, what happens is about 65 to 70% of most resident days, depending on the state you're in, is paid for by Medicaid. Medicaid payment rates are driven by states. They're not determined by the federal government. And so if you have a state that you're already paying Medicaid at rates that are very low or not covering the cost of care, and you believe that you want to increase staffing, that's going to come with an increased cost. You're going to need to have some sort of state buy-in that sort of focuses on increasing those reimbursement rates. The other thing is some states may say we don't have the funds. We can't do this long term, and they may choose not to. So if we're going to implement the minimum standard at, say, a federal level, those types of things need to be into consideration. Where is an existing state? Is the Medicaid reimbursement rates adequate? We need to ask those questions. And if we go to a specific staffing level, is the state willing to spend more money, or is that something where the federal government has to come in to make up the difference? And then lastly, I think what's important to understand is that there's been other research that has said when we have implemented increases in minimum staffing levels by themselves, what we see is that providers tend to come back on ancillary services. Callie Thomas at Brown and myself with Kathy Heyer have looked at some of these states that have implemented minimum staffing levels, and basically have shown that some of these facilities will cut back on staffing on food service, social work, and activities. The next thing I want to just sort of say is that we can also look at an expenditure requirement and what are some of the considerations there. So the NASEM report sort of suggests that we should look at an expenditure requirement together with a minimum staffing level. But the thing is that, hey, we have challenges with a minimum staffing level at the federal level that might require funding from states, and states might not want to buy in. So maybe what we can do is just increase, do a minimum staffing expenditure. That would force nursing homes to spend a certain percentage of their revenue on staffing. One of the problems with that is it doesn't guarantee any particular level of staffing, right? If you think about total expenditures, it's a very simple formula. It's the number of hours of staff times the wage rate plus your fringe benefits. So if the wage rates go up or your fringe benefits cost you more money, you can spend more money on staffing without having any change in the number of hours. And so those types of things need to be considered. Do they actually necessarily result in what we want, which is higher staffing levels, which result in better quality? I do want to talk about one other issue before I get to some actual data. And this is the 4.1 minimum. Most people are probably aware that there's been some advocacy for having a 4.1 minimum direct care staffing level. I just want to sort of point about the context of this. If we look at minimum staffing requirements right now that are quantitative at a state level, there is no state that uses 4.1. In fact, about 2 out of 5 states have no minimum standards, I shouldn't say standards, minimum staffing level requirements. If we look at the states that are the highest, there's California at 3.5, that was implemented in 2019. We have Florida, which has had 3.6 for a long time, although they're now sort of changing who counts towards that 3.6. But if we look at the lower ends, we have states like Colorado and Kansas who are at 2.0. So the thing here is currently there's no state that requires 4.1. The second thing I want to point out is what is the basis of the 4.1? The basis of the 4.1 was a study called The Appropriateness of Minimum Nursing Staff Ratios in Nursing Homes. It was a report to Congress in 2001. The question is, a lot of people cite this, but they don't go back and actually take a look at what the actual study was that made this recommendation. So I actually spent some time and actually did that. And it's interesting to know that the staffing levels actually came from Medicaid cost reports. Phase 1 of the study, I think, looked at 3 states, and phase 2 of the study looked at, I think, about 10 states, Ohio being one of them. And it's interesting to know, so a lot of people are saying this was a direct care requirement. Well, I can tell you from Ohio Medicaid cost reports from that period, it was based on hours paid. Now, what is hours paid? Hours paid is the total amount of time that people are working at the facility with residents, but it's also the times that they're taking lunch breaks. It's also the time that they're getting paid for sick leave. It's also the time that they're getting paid for training. And it's also the time that you're paying people for vacations. So that's what we mean by hours paid. If you look at the PBJ data that a lot of people are looking at, all of those things like vacation, sick time, and lunch is not included. So what happens here is the 4.1 is actually based on a different number than what we're getting from the PBJ because of some of those states. The second thing is having worked with the Medicaid cost reports for Ohio, is the only administrative staff you can break out is the DON. There are other administrative staff who might be there like an MDS nurse that can't be broken out. And so it isn't solely focused on direct care, it's more focused on total staffing. So that's something to keep in mind. A third thing, when they were looking at this study, they did not look at quality measures directly. What I mean by that is they ran regressions to look at what is the relationship between staffing levels and quality. But instead of sort of saying what's the most cost-effective place where staffing is the best, what they basically did was they said, let's take the 10th percentile of quality. And I believe what they did is they said, are you in the top 10th percentile or the bottom 10th percentile? I just can't remember which one it is. And they found the staffing level that's associated with not having a change in that percentile ranking. So they didn't look at staffing itself. They were looking more at, are you sort of in the top of the facilities or are you in the bottom of facilities? And then finally, what they did is they didn't look at what is sort of the optimal staffing level. They sort of looked at what is the threshold in which if we add more staff, quality doesn't improve. But again, they're not looking at quality. They're looking at what's your chance of being in this 10th percentile. And so what I have on my next slide is a way of just sort of saying that. This directly comes from phase 2's report. And if you have here, and unfortunately, they didn't label the axes, but if you look at the x-axis over here, what they're basically saying is what happens if we increase staffing levels? On the y-axis is their sort of, theoretical measure of quality. So what they're saying is at very low staffing levels, if we increase staffing, there's going to be some significant benefits in the sense that quality would improve. But there's going to be at some point where adding additional staff has no detectable benefit. And so what the 4.1 does is it identifies that point, right? The analogy that I like to use is somebody did a study where they basically said, if everybody drives under 10 miles per hour on the highway, we'd have no accidents. That doesn't necessarily mean that we should all be driving at 10 miles an hour. What it means is that that's the point at which there is no accidents. And so what we have is we have a trade-off, right? We will allow people to speed a little bit, go faster than 10 miles an hour, understanding that there is some level of acceptance of accidents. So, as an economist, what I would really want to know is where is the marginal cost of staffing related to the marginal benefit of staffing in terms of quality? And that's not what this is sort of showing. So my comment is I don't want to say that 4.1 is the right number or the wrong number. I just want to point out here that what needs to be done is additional studies to determine what is the optimal, staffing level. And I think using a study from 20 years ago, when we have better data like the PBJ data and things like that, is probably what's required here. And so that's my main point on this. So for the last time, for the last couple of things I want to say here is let's now actually take a look at data to understand where we are in these sort of contexts. And so this is work that I have with UN, Chris Brunt at Georgia Southern, and David Grabowski that recently came out in Health Affairs. And what we specifically looked at was sort of what was the median expenditures and staffing levels in 2019. We looked at 2019 because we know that the COVID pandemic changed a lot of things and made things, made things challenging. And we want to sort of understand what was happening during a period of time in which the nursing home industry was relatively stable. So for the entire sample of nursing homes that we're looking at, we first calculated what was the percentage that they spent on staffing, nursing staff, including the administrative staff, as a percentage of their revenue. And what we found was the median facility spent about 33.8. I can tell you, if you were to look at direct care spending generally, when you include things like, say, a therapist, about 8% of spending is on therapy staff. And when you include other types of areas like that, that number gets to about maybe 66 to 68%. What we also did is we calculated staffing levels. First one we call hours worked, which represents the stuff from the PBJ data. This is the amount of time people are spending in the facility, subtracting the meal breaks and not accounting for the things like vacation and sick time. And then we have the hours paid measure, which includes that sick time and things along those lines. The main point I want to make from this slide is literally comparing the entire sample to the high Medicaid payer mix. These are the facilities that have the most Medicaid in terms of their percentage of residents who are on Medicaid. There's an argument by some that Medicaid pays under the cost of care. Well, what we can clearly see here is that if we look at a percentage of revenues, these high Medicaid facilities are paying a higher percentage of their revenues on staffing, 35.6% of the median versus 33.8. But if we look at staffing levels, whether we look at hours worked or whether we look at hours paid, those staffing levels are lower. So this is sort of evidence that staff spending and staffing levels are not necessarily 100% correlated, right? That there can be these differences. And so what we've done is I've modified this from our paper to just sort of look at what is the distribution of spending. On the x-axis, we have different spending amounts. So it starts with, did you spend 25% of your revenues on, nursing staff, all the way up to 45%. And then the x-axis is what is the percentage of nursing homes that met that various threshold. So for example, if we look at 35, we have these numbers at around the 40% range of nursing homes hit that if you're in the black line. So what are the different colors of lines mean? The red line are those facilities that have the highest Medicaid. So what you can see is that a greater proportion of the high Medicaid facilities are more likely to meet any spending threshold. Whereas the purple dotted line are these facilities that have the lowest 25 percentile grouping of spending, and you can see that they're less likely to meet it. But if we do the same thing, and now we look at staffing levels using the PBJ data, we see the exact opposite. So on the x-axis, you have the various staffing thresholds going from 3 to 5, and here is the percentage of facilities that are able to meet that benchmark. We can see that those facilities that have the lowest Medicaid are more likely to meet every staffing threshold, where those with the lowest Medicaid are the least likely, the highest Medicaid are the least likely to meet it. If we look at the 4.1 criteria using the PBJ data, I have the numbers right here. The low Medicaid facilities, 34% meet that criteria currently, at least in 2019. If we look at the high Medicaid having over 80% of your days paid for by Medicaid, it's only 10%. So what this means is that if we were to use, for example, the 4.1 as the threshold on a national basis, there are a significant number of facilities that would need to increase their staffing. And that goes back to those original questions about, do these facilities have the ability to do that? So the last thing I want to show is from that paper. And in that paper, what we also did is we look at this on a state-by-state basis. So on the left-hand side, what we have is ranked from basically each sort of dot represents a different state, but we rank these guys from the highest percentage of expenditures on staffing as a percentage of revenue to the lowest. So you can see like North Dakota, the median facility spends about 44% of its revenues on staffing. a state like Utah, that number is down around 27%. The other lines, which are green and purple, are just what is the median staffing levels, either coming from the hours paid or the hours worked standpoint. The key relationship I just want to point out here is, as you see, if you thought that there was a relationship between expenditures and staffing, and you saw that this black line went down, we would expect that these other lines related to staffing levels would also go down, and they don't. So it's just another sort of evidence here that, just mandating an expenditure on staffing does not guarantee that you're going to have a certain staffing level. So the last thing I want to sort of point out is just some of the challenges that may exist for the nursing homes if we were to implement some type of minimum staffing level. The first one is obviously occupancy rates are down. So what I have here is running from the fourth quarter of 2019 all the way through the second quarter of 2022 is what is the average occupancy across all nursing homes in the United States. So this is all empty beds added together. It's not the average facility, it's the total number of empty beds. You can see prior to the pandemic, those numbers were around 81%, 80% of beds were full. The pandemic caused a huge drop. Obviously, this is when we had that spike around the end of 2020, 2021. And we do see sort of a slight improvement. We're now back up to about 72%. But one of the points I'd like to make is that in the data, there's now 300 additional nursing homes not reporting anything. That would almost, while I have not verified it, it implies that about 300 nursing homes have sort of closed over this time frame, from the first quarter to the last quarter. A second challenge that we have is, what is the actual cost of this staff? And so using the Medicare cost reports, I was able to identify what is the median hourly wage cost. And I just want to make it very clear what I mean by hourly wage cost. It's the amount that's paid in terms of salary or wages, but it also includes the fringe costs. So when we, for example, say a CNA is getting paid, the median CNA is getting paid 19.6, or the median facility is paying $19.66. That's the amount that's being paid to the worker, but also the cost of the fringe benefits like health insurance and things along those lines. So this is sort of the cost of the facility. If we look at people who are directly employed by nursing homes, those rates have gone up about 20% for the licensed staff, the RNs and LPNs, and about 30% for the CNAs. If we look at these agency staff, which is becoming a bigger issue, those increases are about the same. The main difference, though, is if we look at what it costs the nursing home to employ, for example, a registered nurse, what we can see is it goes from, say, $41 to $60. If we're looking at a CNA, the median number was $20 going to $32. So obviously, it's more expensive to hire agency staff. And here's what's really bad about this. There are reports out here of nursing homes that have, say, a particular worker who's been working there for a long time. An agency staff comes, or an agency comes through, convinces that individual to take the position with the agency, pays that nurse an extra $2 or $3 or $4 an hour, and then literally puts them right back into the same facility. And now that facility has to pay a significantly higher rate. And so that's creating cost challenges. As what's happening, most of these facilities are turning more to agency staff. So what I have here is directly from the PBJ data again, what is the percentage of all hours across the United States that are being spent on that are being basically provided by agency staff? Prior to the pandemic, those numbers were around 3 to 4%, whether we're looking at registered nurses, licensed practical nurses, or CNAs. We get rid of this period because the PBJ was optional during the first quarter of 2020. But if we look at what's happened, is there's been a steady trend upwards. So for LPNs, basically by the end of the middle of summer of last year, we're talking around about 13% of all hours are agency staff for LPNs. For CNAs, it's around, and RNs, it's around 10%. So that's really affecting the cost. And so what I have here is I'm basically showing, well, what's going on with costs. If we look at the operating expense per person per day, what we can see is that it's gone up significantly, around 23% between 2017 and 2021. However, if we look at what's called all payer net revenue, so this is not looking at Medicare or Medicaid, it's looking at all revenue that you get from, caring for patients, that increase was only about 16.8%. And what's happened is, at least from the perspective of providing care to patients, there is this sort of median negative number. They were losing about $4 a day on patient care, about $4 a day in 2019. By 2021, they're losing about $25, $26. What I will note is that a lot of facilities have other sources of revenue, such as the gift shop. They might sell meals. And in particular for 2021, you can see that the facilities still made money, but most of this reflects what's going on with CARES Act money. In particular, the CARES Act money was below this, was affected the net income. And so without the CARES Act money, this number would probably be significantly negative. And I just want to show you a case study in New York, because they're, trying to really enforce this minimum staffing requirement right now. If we look at what happened at New York during this period of time, the revenue went up by about 15%. If we look at the operating expense of those facilities, it went up 22%. In comparison, the Medicaid reimbursement rate that the facilities received only went up by 3.5%. So clearly, Medicaid is lagging behind in the state of New York when it comes to what is the cost of care. And I do want to point one other thing out. So Sam later on is going to talk about this concept called related parties and talk about the, some of the issues related with the Medicare cost reports. One of the things that I often do is that there is some criticism about a related party. And let me explain what a related party is. A related party is that sometimes you need to buy other services. They might be accounting services, they might be medical supplies. And if you purchase those from another business that is sort of got common ownership, we call that a related party. There has been some criticism, and there have been some examples of related parties that have some issues. But what I want to point out here is that what I did in this study is I said, let's look at all those facilities that don't have that criticism. Let's look at those facilities that have no related party transactions, any of that type of criticism. And what we can see is that their costs are still increasing almost 21%. So the point I'm trying to get at here is that there is sort of this issue that costs are rising faster than revenues. And while there are various criticisms that are out there, in particular, this seems to be a national issue. And so therefore, I just want to make sure that that's aware. And then finally, I think the last thing I want to point out is the recent MacPac report that came out in I think it's late January, early February, basically talking about Medicaid and whether it covers the cost of care. The study basically showed that for nationally, about 81% of nursing homes, their Medicaid reimbursement rates do not cover the cost of care, trying to get at Medicaid costs. Some states are significantly different. California, 91%, Delaware, 42%. There is one criticism of this report, which is that they did not account for supplemental payments. I will note that, they were looking at what was actually paid, looking at some what's called TAMSIS data. That doesn't account for what's called these supplemental payments, which are extra payments made to facilities. Most supplemental payments are actually concentrated really in two states, Indiana and Texas. And so while I agree that supplemental payments are an issue, they're not an issue in every state to the same extent. And so whether we agree with these exact numbers, I think that their report sort of still supports this idea that Medicaid is generally not covering the cost of care, at least in 2019, which is what they're looking at. So just to conclude, I just want to make it, if you come away with three pieces of information, I think it's this. Number one, expenditure regulations do not guarantee improved staffing or improved quality by itself. I think that nursing staff is obviously an important component in improving quality. I don't think anybody will disagree with that. I think where there's going to be some issues moving forward is, that extra staff is going to cost extra money, and states in their willingness and ability to want to increase that staffing and funding, that's going to be a challenge. And I think the thing that I would like to make very clear is there's a lot of research that talks about how nursing homes require interdisciplinary teams. That means that they need to look at people who are activity staff. That means they need to look at people who are social workers. And a lot of the talk has been around the nursing staff only. And I think looking at the nursing home more holistically is important, because if we're trying to increase nursing staff and it comes at the expense of things like activities and social workers, that's not going to be good. There's some research that sort of suggests that more activity staff actually helps with behavioral symptoms associated with dementia. So we want to make sure that we're doing what's best for residents in terms of their quality. And so I think looking at that more holistically, and I will just say this, I am happy that I am not a policymaker right now. So just lastly, I'll put this slide up because here's all the references, and I thank you for the time, and I will turn this over to Sam now.
Great.
Your
Great. Thank you, Dr. Bogus. Let me see if I can share my screen correctly. Hold on one second. Just give me a second here. Can you see? Is it full screen now?
Yes, it's good.
Okay. Okay, great. Thank you. Again, my name is Sam Brooks. I'm with National Consumer Voice, for advocacy organization on behalf of nursing home residents and their families. And thank you, Dr. Bobus. It was really nice to be on this panel with you. Really admire a lot of the work that you've done. And just grateful also to have this opportunity to talk. And I just wanted to point one thing out, is that CMS has endeavored to determine what the necessary level of care is for nursing home residents. And they've conducted a study, they've conducted a document review, they've solicited input from the community. And that point behind that is to determine at what level nursing home residents begin to be at a higher risk of harm should that they receive hours of care below it, say 4.1, whatever that number is. And that's irrespective of what the cost is to facilities, what the cost is to Medicaid. And I think that's an important thing to keep in mind. We need to keep this centered on residents and what residents need in order to survive and not be harmed, and to also flourish and have good health outcomes. So I just wanted to talk a little bit about, it's funny that I think this is a timely report, and particularly around the cost analysis and Consumer Voice. Really over the past year has been, well, for years now, I've been really hyper-focused on nursing home financial transparency and accountability. Nursing homes, as Dr. Bobos indicated, receive billions of dollars annually. In 2019, at least 80 billion. That number was even higher in 2020 with CARES Act money. There's little accountability in how this money is spent. And as Dr. Bobos indicated, I'm going to talk about one just element of cost reporting that's called related party transactions. So we were really excited to hear not only the NASEM report call for increased transparency in how nursing homes spend money, but also it's one of the goals of the Biden administration when he announced some historic reforms last year, about a year ago. Unfortunately, I don't have the report ready for today, but I will in the next couple of weeks. We'll be releasing a report documenting, again, how billions of taxpayer dollars are annually funneled through related party transactions, with little to no accountability of how the money is used at all. In 2015, $11 billion went through related party transactions. And as we said, a related party is an entity that does business with a nursing home, and that entity is owned or controlled by the same persons who owns the nursing home. For instance, one chain in 2018 to 2020, this is Life Care Centers, a very big nursing home chain, paid related parties $1.25 billion over that 3-year period. This included $92 million of lease payments to itself. And importantly, these are just line item disclosures. It doesn't say what went into those lease payments, what was utilities, what was mortgage payments, what was insurance payments. All CMS requires on these forms is that it's what the amount was and what was paid. And so little to no transparency in how these reports are, these costs are reported. And often, and we've been looking at a variety, hundreds and hundreds and thousands of cost reports over the past the years 2018, 2020. What we often found was the payments to related parties far exceeded the reported costs. For instance, again, life care centers reported $64 million in related party lease costs. Related parties are required to report how much it costs them to provide a service. In this instance, the related party said it cost them $64 million. However, the cost report shows that life care centers paid $92 million. That's an excess payment of roughly 44%. And importantly, and this is what is so important to nursing homes, is that these payments show up as costs on cost reports. So while it shows that the facility may be losing money, there's this excess payment of, in this case, $28 million that is not accounted for. But that excess payment is not counted as profit. It's counted as a loss. So it shows often facilities that they're operating at a small profit or even losing money. While if you look closer in these related party transactions, if that is profit, we don't know what it is because CMS isn't required to be reported, and CMS doesn't, nowhere on the form does it talk about what this is. And as Dr. Bobus, I'm sure will see, Medicare cost reports often reveal glaring errors in data omissions. Each report is filed under the penalty of criminal, you must swear that it's accurate or suffer a criminal penalty. But often these reports, which have been sitting for years, have omissions in data, transposed decimals, these discrepancies and inexplicable discrepancies in data that just can't be explained by the report itself. And what this leads us to believe, and to illustrate, Brias is a nursing home chain in California. For the 3-year period, 2018 to 2020, their related parties reported $11.8 million in costs to provide a lease to the facilities that Brias owned. Yet on the cost reports, there's reported $152 million in payments. That's an excess payment of $140 million at 1,200%. And this is all on the cost reports. It's all sitting there. It's you can access it. And what this leads us to believe, and one thing I wanted to point out, that this isn't just lease payments. You can do this with any type of related party. For instance, staffing agencies. So facilities may pay higher rates to staffing agencies, but sometimes the facility actually owns that staffing agency. Physical therapy, occupational therapy, insurance companies, food services, life care centers paid $325 million in insurance payments to itself in a 3-year period with no explanation to where that money went. What this leads us to believe is that there is no scrutiny on these cost reports. CMS is not looking at them. Importantly, CMS is required, and Dr. Bobus indicates this in one of his reports, to look at these costs and ascertain whether they're reasonable and prudent. That means if I went out on the open market and bought these same services from someone else, from a third party that I had no ownership interest in it, what would it cost? But there's no way to determine the reasonableness of the cost from the current cost reports because they're just line items. It doesn't say what you got for that amount. So it's virtually impossible. And the HHS OIG has announced last year that it's going to be reviewing this very process to determine whether CMS does this at all. And importantly, related party reporting is just a small sliver of data reported by nursing homes. It raises concerns about the accuracy of all data in these cost reports, including wages. I know And until cost reporting becomes more transparent and until CMS begins to audit and review them, ascertaining the true cost of nursing homes is virtually, we believe, impossible. And one thing I'd want to point out, and I was mentioning to Dr. Robles before, just because a facility doesn't show up with a related party doesn't mean it doesn't have them. For instance, you could be a nonprofit and create related parties surrounding them, and you wouldn't meet the definition of related parties under the CMS rule. So therefore, it wouldn't be reported, and it would actually be an ideal situation for anyone that was looking to use related parties to siphon off money. And it's, as Dr. Robles indicated, I just wanted to point out that the MACPAC report didn't address supplemental payments, and importantly, I don't think the MACPAC authors of the report who I spoke with would say that their report definitively says it doesn't cover Medicaid costs, but they did their best with the information that they had. And in the last paragraph, in the last concluding paragraph, they say we were not able to examine the effects of related party transactions and other practices that may artificially inflate the costs reported on Medicare cost reports. So again, it's an incomplete picture due to the fundamental unreliability of the data on the cost reports. I just wanted to point out, there's this interesting lawsuit that was filed just recently, well, in the past couple of years, by for-profit nursing homes in New York. New York passed a law requiring nursing homes to spend 70% of reimbursement on resident care, including 40% on direct resident-facing staff, and it also capped profits at 5%. Industry filed suit challenging the law. In their complaint, which was just an amazing complaint that they would actually plead this, 176 facilities claimed that they would have had to return to the state $824 million, $313 million of which was attributed to the 5% profit cap. 20 million of this was from nonprofit facilities. And there was no explanation how the other 500 million was spent. So there's a lot of murkiness going on in New York. And although the constant refrain is that we don't have enough money, clearly some nursing homes, for-profit nursing homes, are making significant amounts of money in nursing homes. And also, I just would point you to a series of cases recently filed by the Medicaid Fraud Control Unit, illustrating how some poor-performing homes siphon money away through related parties. Cold Springs Hill Center, they allegedly diverted 22.6 million out of 157 million it received through related parties. And importantly here, it's the New York MFUCU, this Medicaid Fraud Control Unit, that's doing CMS's job, because CMS isn't doing it. And it's all, the information is there. And some of us call it low-hanging fruit. And finally, people are catching up with it. And CMS is going to be in the position where they have to catch up with it. More info on those reports there. And I know we're running out of time. I just would like to say our goal, and I think the goal of the administration and the NASEM report, is increased accountability and transparency in how the money is spent. We just strongly believe that we cannot have accuracy in costs until we have accuracy in cost reporting. CMS needs to be auditing both manually and through some sort of computerized system that flag reports that contain no information. And we agree with Dr. Bose that minimum staffing standard should accompany any spending requirements and profit caps. And also, I think holding owners and operators accountable for inaccurate cost reports is important as well. So I went through that quick for time, but I'm happy to answer any questions. Thank you very much for having me here.
Thank you, Sam. So given the time, we will take a few questions. The first question is to both of you. In any of the policy discussion today, have VA nursing homes, come up in those policy conversations where they definitely have, higher staffing, and they also have a, holistic approach and more connected with their system?
Yeah, so hi, Catherine. Nice to see you on this. I would say that I have not looked at that. As you're more than aware, there is VA information in, CMS data collected on nursing homes, but I have not done a study specifically on VA nursing homes, and it might be actually a nice area to look at a lot of these issues and to see what's happening there. So I really don't have an answer for you. I think that that's an area of research that does need to be done, and it's something that can be done.
Okay, Sam, you have any comments to that question?
No, I think we're in the same position. You know, we often hear from families who have loved ones in VA homes, but we haven't explored really their methods or any practices that they have that might be effective in non-VA homes. Sorry, can't speak to that.
Okay, thank you. So we have another 5 minutes. If you have any question, please type in the Q&A. Okay, Bianca has raised up. Go ahead, Bianca.
Hi, thank you for this great presentation. And just a reminder to folks, go ahead and put your Q&A in the Q&A function. I think we can possibly unmute people too if they want to ask. But John, I'm just curious, kind of in light of Sam's comments around the data quality, what tips would you have for some budding researchers out there who want to use Medicare cost reports?
Well, I mean, it's no different than any data that you're using. What you need to be aware of is that, you know, what I think Sam is specifically concerned with, and what, you know, even what I would be concerned with, is anything that's outright fraud, right? Obviously that there are data errors in this, and one of the limitations of the Medicare cost reports is CMS hasn't really put a lot of focus on it in the last 20 years, so they haven't got a lot of attention. But, you know, as an economist who's used to working with dirty data and even looking at claims data, sometimes when you're working with financial information, you get these outliers. And so that's why you need to use proper cleaning statistical techniques to make sure that you're getting what you're what you're looking at. If you look at all of the numbers that I try to report the medians here, because if there are these outliers, they're not going to be affected the same way, say, a mean would be, or an average. So some of this is, you know, it comes down to cleaning data. Some of it comes down to like identifying outliers that might be potential issues and trying to look at where the data is actually, you know, generous and so, or good. And that happens with any type of data set you work with. And so there are proper statistical techniques to address those issues. And I think it's important for, you know, if you're going to work on this type of stuff, to know those things and go out and try to identify that and be aware of what the cleaning techniques are. And that goes back to your training, you know, that you took in your methods and econometrics and statistical classes.
I just wanted to say something to that too. You know, I agree wholeheartedly with John about CMS just indifferent to these reports. And as a result of that, states have taken up the issue. For instance, California passed a more in-depth cost reporting system. New Jersey has a proposed bill right now, and Pennsylvania passed some regulations. So as more states do this, you'll have more transparency in the data. And I think that will be great for researchers, because even if you're not looking at outliers, there's just not enough information currently within these reports to really do an assessment about the actual costs that go into it. We just need more information.
I have a question regarding the related party. So for example, for staffing, can we get the average audit rate for related party staffing versus independent staffing? Because that's probably the better way to compare the actual cost from related party versus non-related parties.
Well, it's hard. There's just not enough information. So remember, when related parties are reported, they're reported on a sheet and it just says staffing, or it says management fees, $90 million. It doesn't say what those fees are for. So you can't really compare what went into that compared to what you would say get someone who doesn't have a related party. And that's the fundamental flaw in the CMS model, is because they're supposed to do that. They're supposed to be actively comparing the prudence and reasonableness of these costs. So under the system, we just can't make those comparisons, absent a significant audit, which CMS just does not have the resources. They need this information to be disclosed right up front. So
great. So we are right on time. I don't see any question, but the webinar will be posted online. at the Award Network website. And Bianca has posted the link. So thank you so much, John and Sam, for your excellent presentation. I think we hope to hear more from both of you in the near future.
Thank you very
Thank
much.
you so much. Thank you for having me.